Yes, ma'am. You can start the presentation.
Okay.
Thank you.
Hello, myself Dr. Kirtida Joshi, second year junior resident. 2 months old male child born out of non-consanguineous marriage, fifth by birth order, resident of Mumra, hailing from Uttar Pradesh, brought by parents, came with chief complaints of abdominal distension since last 1.5 months, yellowish discoloration of skin since last 15 days, fever 10 days back, and vomiting since 3 to 4 days. Abdominal distension noticed by mother was mainly in bilateral upper part of the abdomen, not increasing or decreasing after food intake. Yellowish discoloration of skin noticed first around eyes and then progressed involving face and entire body over 5 to 6 days. Fever, there was one spike of fever undocumented, mild to moderate, relieved on medication, and there was no repeat fever spike after that. Vomiting, multiple episodes of vomiting immediately post feeding, small in quantity. For above complaints, child was admitted at Kalwa Hospital, where child was kept in PICU for 3 days. Child received one PRC transfusion. Child also had one episode of paroxysmal event in form of tightening of right upper limb and right lower limb and turning of head to the left side, not associated with uprolling of eyeballs and lasting for 15 minutes, which was subsided on some medication given in the ICU at that time. And child was referred to our hospital for further management. There is no history of drug intake, no history of bleeding from any side, history of dark yellow colored urine present, and history of pale color stools present intermittently. No history of similar complaints in siblings. Antenatal antenatal history is uneventful. No history of fever with rash in antenatal period. Birth history is also uneventful. Dietary history exclusively breastfed and immunized only birth vaccine received. Anthropometry wise, child is
Okay, so 2-month-old child has come with abdominal distension since last 1.5 month, which means since the baby was 15-day old, correct? Yeah. So what do you think that would mean to you? How will you start analyzing this?
abdominal distension, cause for abdominal distension. Is it gaseous or uh, any organomegaly or any other cause?
So by what history will you rule out that this is gaseous?
Abdominal distension increasing or decreasing?
Excellent. So going up and down, waxing and waning. If it is there, it tells you gaseous. So it is not there here. So that is ruled out. What else?
Umbilicus, if it was everted or not, or fluid, or any flying fullness.
So all cases of fluid will not necessarily give rise to a everted umbilicus. And again, parents may not be able to tell you everted umbilicus, right? Plank fullness is also something which we have to find out, doctors. So now we are saying one possibility is fluid, one possibility is organomegaly. Anything else? Gas we have ruled out. Then very good. Feces. It's a 15-day-old baby. So for feces, what question will you ask in history to confirm or rule out?
History of passing normal stool, consistency of stool.
Yeah. So with what kind of a history will you be happy? Suppose they say that the baby is passing once in 3 days stool. Then will you think this distension could be due to constipation?
So 3 days is not significant in a neonate.
So how
Yeah.
many days is significant?
Some of the neonate passes stools in one week or like in
Very
7 days
good.
also.
Very good. So what additional history will you ask which
If
will confirm that you are not worried whether it's 3 days or 7 days?
when the child is feeding well and
Okay.
child is irritable or not. That's
Okay. Something more. At the end of those 3 or those 7 days, when the child passes stool,
whether it's
how is that stool?
the hard stools or soft stools consistency wise.
So in a normal baby, when
Color and other
so in a normal baby, what do you expect?
soft stool.
Even after 7 days.
No.
Yes, that is the point. That in a normal breastfed baby, if the baby doesn't pass stool for 3 days, 4 days, 5 days, whatever, whenever it finally passes, it is still not hard. That is the biggest point. Plus, of course, yellow and all that, right? And you said feeding and no distension and all that, right? Now, so you are between fluid and organomegaly. Any difference in that you can make out from history? You've given some history.
Abdominal distension mainly in upper part of the abdomen.
Very good. So that tells you, okay. Now, one very important point. What can cause organomegaly at 15 days of life? Think of that and then we kind of take it further.
Neonatal cholestasis.
So, in cholestasis, first organomegaly or first jaundice? First jaundice and very obvious jaundice. And here there is jaundice is last 15 days. So 1 month after distension, there is jaundice. Any other thoughts?
The onset carcinoma, hepatoblastic.
Okay, malignancy you are saying. Very rare.
There maybe mother might have not noticed icterus like with abdominal distension. She might have first noticed abdominal distension and mild icterus she haven't picked up.
Okay.
So
Though you expect the icterus to be quite prominent, right? You don't expect it to be mild. If it is a biliary tract disease, what you said, right? Any other possibility? Anything else that she may not have noticed? So my question is, at have you can you think of any cause where hepatosplenomegaly comes up at 15 days of life? Metabolic disorder, okay. What would so how would metabolic disorders present in this period, newborn period? They usually present with which anemia? You mean thalassemia? This early, 15 days of life? So I was just trying to say that it may not be at 15 days, it may be there pehle se hi. That is the point.
I think we were just discussing about stools. A newborn may pass stools even after 3, 4 days and still soft. Why? How is that? If you don't pass stools every day, or at least alternate day, the rectum and the lower colon that's absorbing water, and it becomes very hard. You get a stony hard stool at the end of 2 days. Then how can a small infant on breastfeeding 5, 6 days? I've occasionally seen even a 7 days and still a normal state. How do you explain that? The colon is not absorbing water? Okay, rectum is failing to do that. What is the cause? On the other extreme, the baby may pass several stools every day, and both are normal, right? So how can several number of stools every day normal and one stool 4 or 5 days is also normal? Both have soft stools or loose stool, both have a golden yellow stool. How do you explain this variation in normal people? Any idea? And the reason is if the breast milk is completely digested and absorbed, then there is hardly any residue. And the residue to be collecting enough for the colon and rectum to start an urge of passing stool takes 3 or 4 days. So on one extreme, the digestion and absorption of breast milk is so good that there is no residue at all worth passing stool every day. And that's why. And why on the other extreme, the baby passes 10, 12 stools a day. And that is because there is a lot of carbohydrate in that milk. And therefore, there is often a lot of gaseous distension, loose stools, but the nutrition is taken in. Whether the child is passing 10, 15 stools a day or passing one stool every 4 or 5 days, what is common? Happy child gaining weight. And what is common? Stool looks normal. Consistency may differ a little. That is the beauty of it. So now coming to this child, they notice that. Don't you think the newborn has always a little prominent abdomen? So we need to get more details to say that. Do you think it has been increasing? Okay. We imagine it must be increasing. Okay. But we need to be sure because every newborn has a liver which is already there. Spleen is already might be small there. And why is the liver in a newborn so big? Thereafter, it becomes almost getting into the chest. No? So why does the newborn have an easily palpable liver? And when it gets a little more, for whatever reason, it becomes a distension for a mother. So why is that? The chest cannot accommodate many abdominal organs also. So as the chest expands, there is a room for liver, spleen, stomach, everything there. And therefore, we need to get into details that when she started finding abdominal distension, how was the baby? Was the baby feeding well? Was the baby happy? Okay. If that is so, then we come to a conclusion that either that distension may be physiological or it could be so early a liver disease where there is no liver dysfunction. Now, if we consider that type of a liver disease where liver is enlarging, but there is no significant liver dysfunction, one possibility comes up whether there has been a congenital infection. And if that is so, then you get back and say, what was the birth weight? Often birth weight, full-term baby delivered with congenital infection will be small in weight. That might be a factor. Of course, you might get some idea about the maternal illness, but maternal illness may not be obvious. And even then, there is a chronic infection. So one is chronic infection. What chronic infection? What comes to our mind? But what is a Western way of thinking? In India, which congenital infections may be little more common? What is there?
TB. Okay. Anything else? HIV. Okay.
So malaria, TB, HIV. Okay, congenital TB would do that. Congenital malaria would go right. And they will come with liver spleen. Congenital TB will not have fever, low grade. No. But congenital malaria may be little pale. Okay. But liver and spleen, yes. So one possibility whether there has been some chronic infection right from the antenatal period. But that's why we must ask the history for that. If not, then could it be an early developing liver disease? What is that early developing liver disease? If it is a hepatocyte disease, jaundice should come early. But if it's a chronic hepatitis, the jaundice may not be very prominent, and at that age may not be easily observed. So one is whether there's a chronic hepatitis. By hepatitis, I mean hepatocytes are involved. Okay. So that is one possibility. Then second possibility is it's certainly not a biliary disease. Had it been a biliary disease, jaundice would have been very early. Even hepatic disease, jaundice should be fairly early, but we are giving an allowance for that thought. Okay. But the third and possibly more likely is whether it's not a hepatocyte disease or a biliary tract disease, but it's a venous disease. And if it was a venous disease, like a hepatic vein obstruction, like a butt cherry, then the abdominal distension would have been fastly going into ascites. And that's why, again, the history, how fast is the abdominal distension going? If it's taking a long time, then ascites is less likely. Ascites should have developed in a short time. And therefore, one possibility, are you looking at a butt cherry? Okay. One possibility we said is it a chronic hepatocyte disease slowly coming? And the third we said is whether there is any congenital infection. These three are possible. Tumors, very unlikely. And somebody said malignancy, yes, but that's very, very unlikely. Though hepatoblastoma does present in infancy without hepatic dysfunction, but that takes a little longer time. And 2 months or starting very early is little too far. So we start looking at that. Now that child starts getting jaundice. Now the jaundice means, again, you have said high colored urine, etc. So now we know it was a hepatocyte disease only. A butt cherry will not develop jaundice so early. It will develop ascites, etc. And then if you do not, then he might go down into hepatic function. But therefore, now with jaundice coming, we are sure that it's a chronic hepatocyte disease. Now the question is what kind of hepatocyte disease? It has come very early. So it must be something that is almost starting even before birth, if you like, or immediately after birth. That puts me to say, could it be really a PFIC? Okay. That is the intrahepatic cholestasis and familial. Okay. So to me, that's the first possibility analyzing this. But only by this we will not know. Further progress we will see. A PFIC progresses very fast. PFICs are of three types. One of them could go very, very slowly. Another could be recurrent. Get a little better, come again. And the third one will just go down fast and even be fatal. So PFIC has a wide presentation, but many of them would come at this age. And like if somebody came with bleeding at 2 months of age, ecchymosis, first impression would be a chronic liver disease and not a primary hematological disease. You don't rule out the hematological disorders. Same way, if the jaundice comes not at birth, not in the first few weeks, but a little later, then you have possibly a chronic hepatocyte disease.
So now you said yellowish.
Uh, Bursaria first occurred to my mind the first because acute abdominal distension at this age, you will have to think of prehepatic obstruction and therefore ascites. But then the abdominal distension would have been much more quite distended, or not only upper abdominal distension. And in that child, jaundice shouldn't have come so early because that's a sign of liver failure. So the onset though looked something like vascular, that was not so. Now, obstructive, when somebody complains of high colored urine and jaundice and obstructive disease occurs first to our mind, low, it is little too soon for this particular type. Hematological probably unlikely because will not give rise to that degree of most of the hematological diseases are also unconjugated hyperplasia. Yet conjugated hyperplasia because of the blood transfusion. So ultimately, we do come down to hepatocyte disease, probably intrauterine onset. not now. Perhaps obstructive, less likely, and infective may be more likely. So we don't know whether it is a sick child or what.
Uh, s- uh, Here you've mentioned that abdominal distension did not increase with meals, etc. So as Sir pointed out, we need to ask whether over this 1.5 month, did it increase or no? Because that is important for us, right? It did increase. Okay. Now, yellowish discoloration, we've said and we've discussed. Fever, one spike undocumented and no fever spike after that. So that one spike doesn't mean much. You can't make out much out of it, right? Okay. Now, vomiting multiple episodes post feeding, small in quantity. So, talk about this now. What does this mean to you? Does this mean liver disease? Does this mean not liver disease? What are your thoughts?
Galactosemia and tyrosinemia can present with vomiting.
Agreed. So, vomiting, so 100 diseases can present, right? So, what is the first thing that we should do? We have to define whether this vomiting is significant or no. Does a normal newborn vomit?
Yes.
They vomit small quantities.
Hmm.
They vomit immediate post feeding.
Yes.
So we have to first define whether this is what a normal newborn is doing or this is disease related. So how will you find that out? What questions will you ask? Just common sense. This is not medicine. Okay, weight gain. What else?
Acute onset of vomiting. It was not.
Very good. So was it there before or no? So if this baby has been doing this right from the early days, then you don't give it importance to be connected with the disease. But if till 1 month or 1.5 month nothing, and then suddenly this has come up, then you give it importance, right? So do you have all these details here?
Vomiting since 4 to 5 days before admission.
Only 4 to 5 days. But small quantity, not a proper vomit.
Small
So,
quantity.
so we still don't know whether how much importance to give to this vomit, right? Now, child was admitted and received one blood transfusion. So, though Paresar already said, but I want your reasons that if a 2-month-old has got a blood transfusion, and from our discussion it is hepatosplenomegaly and jaundice, then can this be a hematological disease? So tell us reasons why it is not. 1, 2, 3, 4.
Or any chronic liver disease can cause massive bleeds, which can be a cause of blood transfusion.
So will a massive bleed be obvious or hidden?
Depends where the bleed is. If it is a hematemesis or a icy bleed, then
Correct. So you're right. Your first statement is right that a patient of chronic liver disease may need a blood transfusion. We are not denying that. Now we are just learning further that this patient will need if the bleed is big. The point to understand is, can big bleeds not come to our attention? Big bleed, if it is a hematemesis, they will say no that there was hematemesis or there was melena. And what about intracranial bleed? Big bleed intracranial.
man
Sensorium will change, seizures, all those things. So what I'm trying to just explain is that small chronic bleeds can be hidden. Examples, small bleeding from a polyp in the intestine, worms, any other small bleeds can be hidden. But a big bleed is usually manifest clinically, right? Okay, now come back to hematological. Can it be hematological?
Well, RBCs are there till 6 months of age, so chances of hemolysis so early is not that common, sir.
Presentation will be different. Presentation will be different. The child will present in failure with signs of tachycardia, tachypnea, pallor will be there. Here, nothing like that is present.
This you talked of what kind of hematological disease?
Thal actually was.
So how does typically THAL present in infancy? Common presentation. What we use the word garden variety presentation. How does THAL present in infancy? Progressive pallor and abdominal distension, hepatosplenomegaly. At what age?
It's too early for thalassemia. It usually be at 8 or 9 months.
Does THAL get jaundice? So THAL doesn't have jaundice, right? So first, sir already mentioned that this was conjugated jaundice, high colored urine. So hematological or hemolytic anemias are out only, but still THAL doesn't present so early, and nor do the other. So which other hemolytic anemias can present with jaundice and may need a blood transfusion? Let's complete that. Here, though it is conjugated, so out of question.
Hereditary spherocytosis.
Hereditary spherocytosis occasionally. Then anything else? So wrong drug given, G6PD with intravascular, but all that the presentation is totally different, right? Okay. So come back to this. Now, child had one episode of paroxysmal event in the form of tightening of right upper limb, right lower limb, turning of head to left, not associated with uprolling of eyeballs, lasting for 15 minutes. So now I want some inputs from you. One is not associated with uprolling of eyeballs means, does it have any important significance or what?
The paroxysmal event may be a dystonia and not a typical seizure or a convulsion if it's not associated with uprolling of eyeballs.
How will you differentiate dystonia from a seizure? Come on, some thoughts.
Dystonia has typical twisting movement, and usually stimulus is, there is some stimulus that is provoking the dystonia. Uprolling of eyeball, it goes towards generalized seizure, and this is more focal presentation.
Okay. So what are the other differences between focal and generalized? Very good. Awareness, right? So now the difficult part, that at 2 months of age, is it possible to make out whether at this time was the baby aware or was the baby not aware? Because if you think this was a focal seizure, then you have to look for that. I mean, you have to prove that the baby was aware or awake or conscious or whatever. Any thoughts?
If the baby was crying during episode, then he is aware during the episode.
Okay. If the baby was crying, then you can interpret that baby was aware. We'll discuss that. Anything else? So the point I'm trying to make is again that we need to try and get more and more details in this description. The first being 15 minutes is a huge time, huge. So you need to first cross check with them whether it was really 15 minutes. Then whether it was, so for dystonia, as you rightly said, whether there was twisting. But continuous dystonia for 15 minutes is not there. Dystonia is intermittent, right? So it would relax, go back that way. And personally, I feel at 2 months when you get a focal seizure, they are much more focal. You can't have one half side and still it being focal, you know. So we need to get more details.
I think when this child needed a blood transfusion without obvious blood loss, it means that there has been a very slow, ongoing chronic blood loss. And the question is, where is that? The most common cause of such a situation is in the intestine itself. Intestine is a long feet, several feet. Until, so the first question you would have asked is, was the stool any black color? That would have exactly given you an idea that there is a small leakage of blood from there. Considering that as the most common cause, then we relate it to the paroxysmal event. I thought, what question did you ask the mother to say that there was no uh, rolling of eyeballs? Or she volunteered to?
No, I asked if आँख के ऊपर हुई थी क्या बच्चे की, बच्चा आपको देख रहा था क्या? तो उन्होंने बोला कि नो, अब आँख के ऊपर नहीं हुई थी.
But which means the eyes were open? Eyes were open itself means it was a generalized seizure with encephalopathy. The rolling of eyeballs is the next event, but eyes are open. In any seizure-like event, when the eyes are open, it is equivalent to a general seizure with awareness impaired. And that's enough. Rolling of eyeballs has to be seen in an open eye. And what is more important is open eye. Therefore, an observant mother reports it as looking at one side. Okay. But for me, open eye is enough to say that it's a generalized seizure only. Then why is generalized seizure? Now, there is small way of looking at that fever for a day and sudden increase in number of vomits. Now, what does it mean really? Both are not of any significance of localization, but they are significant of some sudden worsening occurring in it. When there is a sudden stress to the body, the first response is autonomic nervous system, and one of the manifestations are vomiting. For example, somebody who runs a full marathon but is not used to, at the fag end, he would suddenly vomit and even fall down and have a seizure. Autonomic nervous system. So the fever for a day and that multiple vomit, soon later the paroxysmal event, indicates to me that in this child with chronic hepatocyte disease coming after a few weeks of life, that we put it as probably a chronic hepatic intrahepatic cholestasis, has now definitely reason for bleeding. And there must have been a bleed up there too. And therefore associate two together, and you say that this is related to bleeding. Okay. Now he again said that it's right and left, one side, so dystonia looks less likely. But for me, open eye is enough to say that this was a seizure. Seizure lasted for a long time, 15 minutes, which is too long. And therefore, this to my mind is a complication of a chronic hepatocyte disorder. And my first possibility is a PFIC.
So the other way, just for discussion's sake, we said that this might be even a congenital infection, and hepatospleno and then coming up. So could the anemia be also part of that and therefore needing a blood transfusion, and now even a new manifestation as another organ of CNS involvement?
See, the congenital infection has two types of presentation. One, where the infection is died out and the patient does not have jaundice but have a hepatosplenomegaly. Only other type of congenital infection is whether there is an active disease. And active disease is very slowly progressing. This is a very fastly progressing disorder, so probably not. But just to make a point that he said, can you name a disease which is primary hepatocyte disease? Okay, but also has a severe anemia due to hemolysis. Hemolysis due to not chronic liver disease, but due to the same pathology that chronic liver disease is caused by. And I'll give you another clue that this child of a liver disease, hepatocyte disease, is older than 5 years of age.
Wilson's. So why do they get anemia? So what is that anemia also called? It's an autoimmune hemolytic anemia, which is not directly related to Wilson liver disease. It's another manifestation of autoimmune.
Incidentally, if gets tired when it is moved 2 hours. So instead, request people to come forward. This also gets tired. This
Hello, another point in seizure is if the seizure is bilateral, then it has to cross reticular formation. And if it has to cross reticular formation is the seat of consciousness. So a bilateral seizure must have loss of. This child had bilateral. There's no question that this was a seizure and not that. When I was thinking about the anemia, even in a congenital infection, the degree of anemia perhaps may not be as severe to demand transfusion.
Sir, I agree. I'm sorry for saying this, but I feel sometimes the threshold for giving a transfusion of people is also low. So to that extent, they end up giving a transfusion.
All these things, that they must come out with a point again. Otherwise, how do
Okay, history of pale colored stools intermittently. What does that mean? So tell us what it means and then take it to the whole disease in any way that you can.
Pale color stools usually signifies biliary tract disease, basically. Biliary atresia present with pale colored stools.
You said pale colored stool signifies biliary obstruction. Commonest we see is biliary atresia. Do you think this is biliary atresia in this child? You are shaking head vigorously. Good. Why?
Pale color stools present intermittently, means sometimes it's normal, sometimes it's
That is one reason. What else in this story? You came a little late, but are you know the full story? So what else is against biliary atresia?
Biliary atresia, the child won't be this much sick.
We don't know whether it's a sick child. Seizure, you are saying, that's why sick. Okay. So biliary atresia can also have bleeding, no, as sir said. Liver disease, bleeding, vitamin K, coagulation factors, and bleed intracranially and get a seizure.
The age of presentation.
So what about the age of presentation? It's too early. Tell us exactly what you mean. See, we have to speak, then only we'll learn. It's very good that all of you are taking part. Don't worry about mistakes. We are all making mistakes. So you're right. What about age of presentation? So if jaundice came up at 45 days of life, it is late. It is not impossible, but it is quite late for biliary atresia, right? Of course, they may not have noticed this, that. But the typical biliary atresia that we see, they see their jaundice much, much earlier, right? Okay. So then what else can this mean? You're saying biliary obstruction, but you're saying not biliary atresia. So then choledochal cyst. It's characterized by intermittent obstruction. So we've got some history to suggest there would be hepatosplenomegaly also in this child, abdominal distension. So we said there is a liver disease as well. So all that is very less likely in choledochal cyst. That is one. And sorry,
Usually present with infection.
not necessarily, but in fact they can present much later in life also. You know, a triad of intermittent jaundice, pain in the right hypochondrium. Okay. So this is unlikely to be that. Anything else? Sir mentioned something while analyzing. Which are the other forms of obstruction of the biliary tract besides extrahepatic biliary atresia?
Hepatocyte injury with hepatocellular swelling, which will cause a bile duct obstruction.
Okay, very good. That happens when more classically in the rising phase of a viral hepatitis. So in a viral hepatitis, when the bilirubin goes beyond 10, 15, the cells are so swollen that they block the canaliculi and you get a phase of as if it's obstruction, right? Okay. Anything else? So sir said no intrahepatic paucity of bile ducts or intrahepatic cholestasis. So that may not have a constant obstruction or a constant pale colored stools. Now tell us the anthropometry and further.
So anthropometry weight of the child is 4.7 kg, which is -2 to -1 standard deviation. Height is 61 centimeter, 1 to 2 standard deviation. Head circumference is also normal. Weight for height of the child is less than -3 standard deviation, which signifies failure to thrive. So I am not. Height is 61 centimeter and weight is 4 pounds.
Actually, I always fail to understand this. See, your weight is 4.7 kg. And you are saying it is -1 to -2 standard deviations. So which means normal or abnormal? Normal. What is the height? 61, which is 1 to 2 standard deviations. So normal or abnormal? So normal upon normal is less than -3 standard deviation. Normal weight upon normal height, weight upon height is less than -3 standard deviation. So where is the catch? And you said birth weight was 2.4 kg and this is a 2-month-old baby. How much has this baby put on?
2.3 kg.
2.3 kg in 2 months. Good, bad, poor? Good or very good? What is the normal weight gain in a month? 900 grams. So this baby has put on more than 1800 grams in 2 months. So it is too good. And then you are saying weight for height is less than -3 standard deviation. So failure to thrive. So where is the catch? Come on. This is just a mathematical trick that you have fallen for. Weight is -1 to -2. So it is less than the 0 midpoint, but it is still normal. And height is plus side, but it is still normal. So that is why you are getting that weight for height as so low. You cannot call this failure to thread.
I think there is a large liver, large spleen maybe. Okay, there's a hepatocyte dysfunction, so there could be also some edema, we don't know. So we'll have to give an allowance to that 4.7 and bring it down to some level. That's the way to look at it really. Because if you look at 61, this child is 2 months old. So considering 50 centimeters at birth, what should be the length of a 2-month-old child? 11 centimeters more in 2 months? So how much do you gain length in 2 months? This child has gained 11 centimeters. So itself, there is the reason to discuss tall stature. Born with that. 11 centimeters. How many centimeters you gain in the first 2 months? Three centimeters per month. 6 centimeters would have been fine. This is 11 centimeters. What does it mean? Abnormal length? No. Possibly an abnormal measurement. Very likely abnormal measurement. Okay. Because 11 centimeters is impossible, and that's why your weight for height and all are going haywire. He may not be FTT, but he's certainly not normal nourished. But I think that's the way. 61 is too much for 2 months.
When you take the length, first you put something on the head side. And when you stretch the leg and make it straight, the child slides. And if you don't take that into account and again push it further, you are going to get that 2 centimeters, 3 centimeters. Always when you press like that, the child always slides down. So again, you have to adjust or first adjust the leg and then put the side on the side of the head.
Chalo, start speaking what on observation, whatever you can make out, whatever you can observe.
The child is deeply icteric.
So deeply icteric. What else? Important negative findings also you must learn to look for and speak. So what other important findings on the face would you
No
look for?
periorbital edema.
Okay, periorbital edema you don't much expect at this age, but okay. Anything else on the
No
face?
characteristic faces.
Very good. So no dysmorphic features or particular faces. That is important. Then skull size, head size.
Appears to be normal. No microcephaly.
Okay.
No distended veins on the neck.
Okay. What about the growth now?
Well grown for a 2-month-old child.
So length looks good only. And what about the muscle mass and wasting and all that?
No obvious wasting.
Doesn't look wasted, looks okay. Fine. Abdomen, can you see anything?
Distension.
Okay, distension, then
Umbilicus is stretched out.
very good. Umbilicus is pushed down. Now, just for practice sake, I am asking you, this inspection findings, is it flank fullness or is it not flank fullness? Not. Everyone agrees? Very good. So learn to differentiate between flank fullness and other kind of distension.
Are you so sure? The whole abdomen looks pretty big to me. Okay, looks almost all round. So you're right, but just convince me that lungs are not full. Somebody might say, no, looks a little full, you know. All that I want you to know is that when you talk about lung fullness, it is like this. And this is like a pregnant woman up here, but not on. So when something is flatter and then becomes typical like this, whereas here it is dominant, right?
So anything else on observation?
Would you like to auscultate this child? But you must tell me the reason why. Of course, you say it's a normal part of clinical examination.
Some syndromes can add murmur like Alagille syndrome.
Very good, very good. Okay. So one of you palpate the abdomen quietly and tell us. You've not seen, na? Come quickly. It's okay. Yeah.
Liver is palpable around 7 to 8 centimeters below the right subcostal margin, firm in consistency, and with rounded margins, non-tender, and left lobe of liver is palpable. Spleen is palpable around 2 to 3 centimeters below the left subcostal margin, firm. Spleen is not.
Just for technique, please keep your hand always flexed only at the metacarpophalangeal joint. Only this flexion is allowed. Okay. Don't do 1, 2 finger. Don't do like this, like this. Do this only, always. Okay. And you will go up from here, and with each inspiration, you will try to flex at the MP joint. So try to show that your technique is always correct. Okay. Fine. We have any other important positive findings to see? You are going to present no, further. So
Arrival.
hold close.
On arrival to the hospital, there were findings. Now the child is stable.
Okay, fine. Fine.
Developmentally, child is appropriate for the age. So summary, 2-month-old male child.
Endings, anything else? You are giving us the examination findings. No, we interrupted you.
Before examination summary.
Okay, okay, sorry.
2-month-old male child presented with abdominal distension, jaundice, and vomiting with pale color stools, with one fever spike and one episode of convulsion in a birth and developmental normal child, is a case of acute decompensated liver failure with hepatic encephalopathy secondary to neonatal cholestasis or neonatal hepatitis. So on arrival to the hospital, which was 15 days back, child was afebrile, child was drowsy, heart rate was 110.
Not moving there. इधर से full screen कर.
On arrival, child was afebrile, drowsy, heart rate of 110 per minute, respiratory rate of 36 per minute, saturation maintained at 99. Extremities were cold up till forearm and mid leg. Pallor was present. Anterior fontanelle was tense, non-pulsatile and bulging. Icterus was present. No dysmorphic faces. Chest normal, spine, limbs genitally normal, and skin yellow. Yellowish discoloration of the skin was on the systemic examination. On inspection, distension was there, but no tortuous veins or scar. On palpation, abdomen was soft, non-tender. Liver was palpable, firm, 5 centimeter below right costal margin. Sharp borders, and left lobe was palpable of 2 centimeter. Spleen palpable 2 centimeter below left costal margin. Smooth surface. Dull note over organomegaly, but no free fluid. Auscultation bowels were present. Rest of the systems were within normal limit. Drowsy. 2-month-old male child presented. 2-month-old male child with hepatosplenomegaly and jaundice in a birth and developmental normal child is probably a case of acute decompensated liver failure with hepatic encephalopathy with raised ICT secondary to neonatal cholestasis, most likely biliary atresia, followed by metabolic causes and neonatal hepatitis. So this CBC is done here after one PRC transfusion, which was received in Kaiwa Hospital. Hemoglobin is 10.3, hematocrit is 33, WBC 12,500, platelets 2 lakhs, mean corpuscular volume 79, MCHC is 24.5 and MCH is 24.5, MCH is 30.6, PT 30.2, INR was normal 1.1. Total billy of 13.9, direct billy of 9.1, OTPT of 199 and 93, alkaline phosphatase 461, total protein and albumin 6.2 and 4.3, GGT was 288, and RFTs were normal, CRP 0.9. We also did urine for non-glucose reducing substance, which was negative. Hepatoportal Doppler we did, which was suggestive of biliary atresia with altered liver ecotexture. And CT brain was done, which was suggestive of acute intraparenchymal hemorrhage with moderate surrounding vasogenic edema in right frontal lobe, largest measuring 2.6 to 2.6 into 2.2 centimeter, volume 7.7.
Why did this child bleed in the CNS? Any thoughts?
chronic liver disease.
So what is the mechanism of intracranial bleeding in chronic liver disease?
Liver is a site for synthesis of coagulant factors.
So prothrombin time is normal. Platelet
But-
count is
but-
also normal.
It is after the transfusion of one FFP and vitamin K might be. So it might be become normalized due to that.
Correct. Yeah. So about biliary atresia, I mean, we need to, at least for our learning, go back and ask the history properly all over again as to when did they notice jaundice, etc., and that abdominal distension, because the sequence that we got was so different that we put biliary atresia lower down in our list.
There is always a problem of differentiation between neonatal hepatitis and biliary atresia. At one time when we were trained, we waited and waited to differentiate one from the other, and then got into trouble because every biliary disease or a hepatocyte disease became hepatocyte failure. The point against biliary atresia are too many on this shelf. So what the imaging says may not be related to what we actually see, because both look very similar. A chronic hepatitis has a biliary obstruction as well. Now the question is, the radiologist finds commonly a biliary obstruction. He doesn't know the hepatocyte inflammatory disease or hepatocyte dysfunction. That's biochemical. And therefore, possibly, we need to discuss with them if this is the story. Biliary atresia may come a little later after a few weeks. That is right. But it never comes with abdominal distension. Liver is not enlarged in biliary atresia unless a biliary cirrhosis occurs. So the sequence of events is jaundice, maybe even at 1 or 2 months for the first time. If the depends on the severity of obstruction, but the story starts with jaundice, and at that time examination there is no liver and spleen. If this story started with abdominal distension, that's number one. Second is a biliary atresia causing cirrhosis and progressing fast into hepatic encephalopathy is also very unlikely, because biliary cirrhosis also goes on slowly worsening. This child has progressed very fast in a short time. A jaundice appeared at 6 weeks of age, and by another 2 weeks, he is going into hepatic encephalopathy. Biliary disease doesn't do that. Biliary cirrhosis would not have occurred by then, though the liver damage could have started by then, but biochemically. So I think we need to discuss with radiologists as well as the hepatologists. My diagnosis is intrahepatic cholestasis, and the best bet is a PFIC. That would be still hold on to that.
Any questions? Okay, we move on to the second.
You bleed actually.
Sir, no, so he was transfused no, at that place. So now today's values we don't know. That day must be deranged coagulation wise. Second case.
Good evening, everyone. I'll be presenting short case today. 6 year, 3 month old boy, third by birth order, born of non-consanguineous marriage, hailing from Hyderabad, resident of Dharavi, Hindu by religion, bought by mother, informant being mother reliable, came with chief complaint of deformity of legs since 1.5 years, increased urinary frequency since 4 months. Child was apparently all right 1.5 years back when he developed deformity of legs. Initially, he was not able to run. Since last 1 year, child is not able to walk and stops after walking some distance due to pain in the knees and ankle. Currently, child is not able to stand without support since last 6 months. Mother also noticed bowing of legs since 1.5 years. For this complaints, child sought some medical attention on OPD basis. X-rays of hand and the leg were done, and child was started on some sachet medication for 3 months to be taken once a week in August 2023. Mother also noticed there is increased frequency of maturation since 4 months. Earlier, child used to pass 2 to 3 times per day. Now passes 6 to 8 times per day with increased quantity of urine associated with bed wetting, associated with increased oral intake, that is 2 to 3 liters per day. Mother also noticed child is not gaining appropriate weight and height compared to other siblings. History of delayed dentition is also present. There's no history of burning maturation, no history of dental abscess, no history of tetany, no history of pallor, no history of loose stool vomiting, no history of jaundice or fever, no history of trauma to the lower limbs, no history of seizure, lethargy, unconsciousness, no history of fever, recurrent infections or cough, no history of any bone pain or tenderness, no history of night blindness, rash, ataxia, no history of repeated fractures, and no history of any feeding difficulties. Past history: one admission at 3 to 4 months of age for pneumonia for 7 days. Child required O2 support and was given some IV medication. ANC history is uneventful. Birth history was also not significant. Immunization status: child is immunized till 5 years of age. Development history: all the developmental milestones were achieved by the child before illness. Currently, gross motor child can only stand with support. Fine motor, social, and language is normal. So my impression is isolated gross motor delay. Diet history: child consumes mixed diet. There is calorie deficit of 530 kilocalories and protein deficit of 6.6 grams. Family history: there is no history of similar complaints in the family. Socioeconomic wise, belongs to lower middle class. Summary:
So what would be your first thought when this is the chief complaint? 6-year-old has come with deformity of legs since 1.5 years. So what would be your first thoughts?
vitamin D deficiency.
Now, anybody wants to bring up a point against vitamin D deficiency? Or you want to add to that? So suppose I ask you, when have you classically seen rickets? At what age? What will be your answer? 1 year, when child started walking or whatever. So that's the commoner age of presentation of vitamin D deficiency rickets. So now try to go to all the different ramifications of this. What else could it mean? Come on, everyone, think. Could it be that he has been getting deficient since 1 year of age and now he's getting very worse, very severe? That is why he has got now deformity. He's got untreated. Come on. That is one question. Try to answer that. Second is, could it be something else causing rickets? Not just vitamin D deficiency, but something else causing rickets. Take the mic.
Chronic kidney disease can cause rickets. And sir, previous question, there might be some early deformity which could be progressed till now and mother get attention now.
The possibility, but it is very late, मतलब 6 old.
So I will ask a related question and then we'll come back to this possibility. Suppose you see a 1.5-year-old with rickets versus a 6-month-old with rickets. Do the clinical signs differ?
Correct.
What difference?
For a 6 years old, the wrist widening may be there, frontal bossing, these are more prominent features. And for 1 year old, there may be more bowing of legs.
Why?
Because the milestones is achieved that time, the due to weak bones, the due to pressure.
Excellent. So if he has started walking at 1 or 1.5 years, his bowing and deformity will start at that time. And it will not start at 4.5 years or become noticeable at 4.5 years. So that first possibility that he was all along nutritionally poor and he has now become severe, so they have noticed him, nutritional vitamin D wise, that possibility is less likely, right?
I don't know why you are discussing rickets at all. The disease is only in the lower limb. Is rickets a lower limb disease? Or it's a generalized disease? That itself throws out rickets. If I have only edema feet, nowhere else edema. Okay. Then I start looking at whether there is an inferior vena cava obstruction, varicose veins. Yes, local cause. So this has to be local cause. Don't bring in general problems to me at all.
No, but my 6-year-old is only going to walk on 2 legs, no? Unlike a younger child, he's not going to crawl. You're not going to see wrist widening and things like that. You're only going to see lower limb deformity.
Sir, that depends on type of rickets. Hypophosphatemic rickets do usually present with lower limb deformity, mainly, and not other findings.
Right. But hypophosphatemic rickets also involve the rest of the bones. You're right. So the point that you want to know is that you should ask right at that time, have you seen any other swellings at the joints? Okay. How is your growth? Is the spine involving? How does the head look? Big? No, no, sir, head looks all right. Which means what we are trying to say is that this generalized rickets must be first picked up by the history itself. You're right. It is rickets and nothing else. Okay. But you want to convince yourself that, yes, everything is involved. So that is number one. Then, if you ask the mother, do you have any prominence here? She said, no. Now you are gone, no? Now generalize it out. It should be involved, no? So the point is, if head looks very likely to be normal, and there is nothing even on examination maybe, it means that the rickets have manifested much later, and therefore deficiency is out. Okay. Now we said that if rickets started early at the right time, deficiency, and they were not treated, would they go on worsening? Anemia not treated goes on worsening. Okay, deficiency. Every deficiency goes on worsening, right? So if ricket vitamin D deficiency not treated, would it go on worsening and then the legs get bent? Why not?
Renal compensation, and we have calcitonin. The endocrine system will look after calcium and vitamin D.
What he's trying to probably say is that rickets is the disease of growing bones, and the nature says stop growing bones. Then the rickets won't worsen. No? What she meant probably compensation is that, and this at one time used to be called as atrophic rickets. That means rickets are atrophic. Okay. And therefore, if a child is not treated, he would not keep on worsening with rickets, but of course his growth will go down because the body will compensate. That's what she said. But how will the body compensate? First, you say rickets is a disease of growing bones, and the nature stops growing. Okay. So my question to you is, if I have a hypothyroidism also, where my bones are not growing, so rickets will never appear, no? Please give a thought. I want you to stimulate your gray cells. Okay, it's not important, but thyroid, the bone may not grow in length, but this child, if he's not exposed to sun rays or is just sitting at home, then he would develop, the demonstration may be difficult. Okay, but still there could be epithelial enlargement or whatever other sign. And therefore, this is certainly the, so what have you come to conclusion? A late onset, progressive rickets with prominent signs in the legs, in the history. And that's what you said, right?
Any bone deformity should start with the sentence, this is a case of skeletal dysplasia. You cannot jump to the diagnosis of the case. Then you describe what kind of skeletal dysplasia, and you know there are two basic, short trunk and short limb. So you have to hear mention about whether it is short or not, because epiphyseal enlargement can be seen in epiphyseal spondyloepiphyseal dysplasia also, and the spondylo part may not be very apparent, but the epiphyseal enlargement will look exactly like this. So say that it is a skeletal dysplasia. Then out of the skeletal dysplasia, whether short trunk or short limb, and apart from that, whether there are any involvement. And then you may say probably here the most important finding is the epiphyseal enlargement which is going on. There are no other deformities seen elsewhere, and they are not exactly like rickets and bowie. So probably this is rickets and not epiphyseal, this other skeletal dysplasia. And then obviously the later the onset of the deformity, more likely to be a catabolic period. When the growth is maximum and the supply is minimum, which is in the infancy, it didn't develop. And when the growth is little less and the chances of supply are better, he developed rickets. So it's exactly opposite of what should happen. So later the child with an active rickets, the rickets, signs of rickets does not mean that these are not healed rickets. He may have had rickets earlier. And today, if you see the deformity, does it mean it is healed ricket or it is active ricket? I say this is healed rickets. The epiphyseal will not show changes clinically as early as that. So why is it not a healed rickets? Because the symptoms are progressive. Okay, so you would have recovered long back. Now the healed rickets are there. As time goes, he's getting worse. So this is active rickets. Okay, and active rickets at a time where they are supposed to have minimum growth is a disease which is less likely to be a deficiency rickets and more likely to be metabolic.
Talk about deformities, make sure what kind of deformity. For example, if a child develops multiple fractures, also there could be deformities elsewhere. But this is a progressive deformity of the same type. And therefore, diagnosis is straight away that late onset, always metabolic. Okay. Now, why is the suddenly the urinary symptoms have started coming? Okay. What is it? So how can rickets cause renal disease? It's not renal disease causing rickets. Rickets came first, right? Renal disease came later. So the rickets can't cause renal disease. Renal disease can cause rickets.
There's some late presenting RTS can cause.
So she's saying that renal disease is causing rickets.
So long that deformities are worsening, and at the fag end of the story is the renal problem. No, you cannot accept that. You can't have hemolytic anemia worsening and now suddenly splenomegaly coming. No. It has to be rickets causing renal disease. Logic demands, no? How can renal disease cause rickets? Which is first? Renal first, no? Here, rickets is first, and after several years, renal problem has come in. I think to have nothing to do with each other.
The rickets could be the initial manifestation itself of the renal disease. And then as the renal disease progressively worsens, we are getting the renal symptoms.
So, yeah, you want to say something? So, you are right. It only means that a slowly worsening renal disorder in terms of function, which is not easy to pick up. And what is that symptom? Polyuria is very difficult to pick up. Because generally you ask, पेशाब ठीक होता है ना? हाँ. Now nobody says, अरे ठीक क्या, बहुत ही अच्छा होता है. Okay. So that is not likely. So can you clinically examine and say, this must be polyuria only? Because symptom of polyuria is not easy to make out. Okay. Unless you ask how many times, how each time, large amount. But suppose history is not very clear, would clinical examination make a difference? And the point I'm making is, if you have a dehydration in a child who is passing too much of urine, then you obviously have a polyuria. Dehydration is associated with oligoria. And if you have a urine plenty and child is dehydrated or asking for more water, thirst, okay, but dehydration or not is a good important. So this is renal only. And what renal came up later, it must have been right from the beginning. Any reason to call it as a chronic renal dysfunction? Genetically determined, metabolically abnormality, so renal tubular disorder. Why does it come up so late? What's your reason for that? You get my question, right? It's a functional disorder which is present since birth, but manifesting later. Why is it manifesting later? Come on, some thought, logical. Nelson won't mention this because Nelson expects that we are all logical thinkers.
If the renal disease is that slowly progressive, then possibly initially the kidneys of the child were able to keep up with the fluid volume. And now that the child has grown, they're not able to keep up with the volume of the fluid. That's the guess.
Yeah, so basically renal tubular defects, there'll be loss of certain electrolytes, all that dysfunction or disequilibrium has to build up. And initially there will be compensation, there'll be secondary hyperparathyroidism. Now kidney is your site for that second hydroxylation of vitamin D that will go down with time depending on what type of disease it is. So all these multiple factors will worsen it over time for it to manifest, right? So it may not manifest early. Another important thing, sorry, another important thing is rickets painful? Here we are they are saying that a child is not able to walk and stops after walking some distance due to pain in knees and ankle. So rickets is not painful. So something wrong. I think we got the whole story wrong and maybe it is something else. What do you think? So saying pain is inflammation. So is this some myositis? Is this some rheumatological disease? So pain in knees and ankles. So what would you, how would you logically think and approach this? Is it arthritis?
Maybe the child just stopped because there could be lethargy. She's also saying that there's no appropriate weight and weight gain or height gain. There must be some nutritional
Yeah, but
deficiency.
that kind of lethargy doesn't make you stop walking. And it's clear that they've said that it is walking some distance due to pain, stops due to pain. So in other words, you have to try and find out the anatomy of this pain. Where is this pain coming from? Is it from the joint? Is it from the muscle? Is it from the bone? Is it from any other structure? How do you find that out? Joint, what question will you ask? Okay, so one is at rest. Second, joint usually has to swell up, no? Simple. So any joint swelling, redness, which is not there, I presume. So it is arthritis is out. Okay. How do you pick up muscle pain clinically? Very good. Relieved on pressing. So you would ask that whether this is relieved on pressing or no. And I presume you will get an answer no. Doesn't get relieved on pressing. So this is likely to be bone pain. And why is the bone pain? Now try to connect everything. You already talked of renal disease. You've talked of rickets. So why would they get bone pain? Very good. Osteoporosis, bone resorption. So there is a big degree of secondary hyperparathyroidism attempting to compensate, but in the bargain causing a lot of bone resorption and osteoporosis, right?
And because of that, there could be even minimal bone injuries, fractures. And of course, not obvious. Okay, but I'll give you another reason for bone pains in this child. After all, every deficiency is a deficiency disorder, right? So you must be having vitamin C deficiency also. C and D. And C will be very painful. Right? Logic demands, no? One vitamin is another vitamin. After all, PEM is everything deficient. So why not scurvy in this? So simple, no? Give him 500 milligrams of vitamin C and finish it off. We don't know, no? She will now say, gums are bleeding, barbutic rosary. She will say everything. Wait for a minute. But just throw my opinion out. And say, how the hell you are talking about vitamin C in this child?
The intake of vitamin C has to be almost nil for a good period of time for you to have vitamin C deficiency. It's not that is not that bad.
First, I fooled you by saying this is deficiency and that is deficiency. This is not deficiency at all. No. This is not a deficiency disorder. I should bring in another deficiency at all, right? In that what she presented, she said no A, D, etc. You put up something. That was multiple deficiency. This is not a deficiency rickets. So we have no reason to.
And sometimes deformity also can be a cause of failure to walk. There are too much deformities here and all, which often happens. He can't walk with bent leg. And therefore, the weight transmission is wrong. There can be pain just because of the deformity also. So both the factors may be operative here.
I just will remember one of the senior pediatrician from Raipur who stayed in the hospital building only, his clinic and hospital staying upstairs, never met the sun rays at all. And at the age of 50 or something, was being investigated all over for multiple myeloma because he had only body pain. And finally, he said, he'll come to Mumbai. And we said, first, as you come from the airport, meet at Nanavati Hospital, endocrinologist, Dr. Nanavati himself. And when he looked at him, he said, don't worry, just get your vitamin D, calcium, phosphorus. And he had literally rickets, deficiency rickets. Okay. Now, Earlier days when it's school time, etc., I used to play outside surely. But thereafter, and when initially he had not much of work, he would go out. Once his work increased, there was no vitamin D coming out. So he did not have rickets, but he had osteomalacia. So all that he required was go home, take vitamin D, etc. Fact of life. And several weeks he was being investigated for hematological disorder. So such things do happen at one time.
Point about the sun rays and we are getting vitamin D. The sun rays have to strike the earth or the ground at an angle more than 45 degrees. The morning sun rays, where the sun rays are very slanting, the wavelength of 450 micrograms is cut off. And therefore, those sun rays are not responsible for giving you the advantage of vitamin D. The sun rays have to come after 45-50 degrees. That means sun rays after 11 o'clock and maybe 1 o'clock or something are the ones which have that wavelength and therefore useful for. So I keep my baby at 6 o'clock in the morning in sun rays to get the vitamin D is not really true. Only those who go to Juhu Beach and lie down there for sun bath are the useful ones.
On examination, child was febrile. Pulse was 90 beats per minute, regular rhythm, good volume, equal on both sides, no radial, delay, or radiofemoral. Yeah, he's there. Anugrah.
On head to do examination. To begin with, there does not seem to be any apparent, like there is no microcephaly or macrocephaly or any head shape abnormality. Dentition is poor, like this. It is not. Uh, the the muscle mass does not seem to be evident. Sure.
So in connection of what we were discussing, there should be one statement that should come from you immediately, which is kind of challenging all our discussion.
Going.
No. Boeing, okay, talk about Boeing. Whenever you start observing, what are the two things you always talk about?
General,
nutrition.
Built nutrition and
general condition of the active.
active, sick, not sick. What does he look like? Very happy, comfortable, right? We were discussing chronic renal disease. So we just make that observation that he is looking very happy and comfortable. Okay. No alopecia. Okay. Fine, now go on.
Otherwise, the muscle mass does like seems appropriate.
Hmm.
And
So now talk of the whatever deformities you can see.
the ankle, like, there's ankle. There's wrist tightening as
There's wideness of the wrist and bilateral ankle joint.
What else? Ankles are prominent and what else?
Bowing of the lower limb.
So bowing as in, you want to describe that bowing? Is it the usual bowing which we see? So what is this? No, what is valgum? Valgum means what? In general, the word valgum means the point is in abduction from whatever reference point you are taking. This is forward bowing of the lower end of the leg, right?
Then infants also have a bowing. What kind of bowing is
Januvaram.
Upper 2/3 and a lower 1/3, or maybe upper 3/4 and this is typical of kids. While the normal bowing is like this. This is like this. It's not like this. Angulated here. Literally, there is an angulation. There might have been earlier a fracture also which has been. See, this is not the bowing of what we see physiologically. Want to take the movements of the joints?
Whatever other palpatory findings. So tell us, palpate that area and tell us what you want to tell us.
There's no joint movement restriction. He's
So what are the classical signs of nutritional rickets at the ankle? Is it there, double malleolus?
The upper prominence is contributed by the enlarged tibia, and while the lower one is the rear malleolus.
it's not tender, like he's not flinching, even if the mother is saying it is flinching, like it does not seem to be tender.
Upper limbs, knees, the prominences here, upper end of the tibia. Can you appreciate that? Very rarely you see in deficiency rickets. The tendency to go outwards as you extend, going outwards and then coming in because of the deformity. Significant wrist wide. Postopondral. थोड़ा शर्ट ऊपर नहीं बैठे बैठे ना बसून ठेवा आता How do you distinguish this from that seen in scurvy? And the sharp edge there, but in scurvy, it's actually so to say dislocation at the level of rib and the costly. Here there is no dislocation. It's not kind. Harrison's sulcus. You see yeah, there is a gap there. You slide your finger, yeah.
You will see two mountains with a valley. So that is the double mountain.
Is active rickets or healed rickets?
Active rickets.
What are the signs of activity?
One, the costochondral junction is prominent.
Yeah, long back. Now it's not healed. Deformity will take time to get, so to say, corrected. No. So presence of this he may have had severe rickets when he was 1.5 years, and now it is getting, so to say, molded. So presence of signs may not tell you active rickets in history, number one, and on physical exam.
Progressive disorder, so that's now. But would you try to look at whether there is a subclinical signs of hypocalcemia or tetany? Subclinical, difficult. Only those who invented must have seen once. Nobody has seen thereafter. But what are those signs of subclinical tetany? So can you make the tetany manifest when it is dormant?
One is Crochet sign and one is Vostok sign.
We inflate the BP cuff and then hold it for some time. And then we see the posturing of the thing between systolic and diastolic pressure. And then we see the change in hand posture. It's tapping or tapping.
Okay. Any other positive findings? Is prominent.
I checked it. Today only I have checked it and it was 90, like, approx 50th centile only. 98 by 60.
It may be tubular disorder.
Very good. Tubular disorder. So when I told you in the beginning that he is not looking sick, there again you should have differentiated and said that a renoparenchymal chronic renal disease leading to secondary hyperparathyroidism, all that we discussed, is a sick child. But a renal tubular disease may not be a sick child.
So respiratory rickets, we have hypocalcemic variety. They are the ones who may have hypotonia, and they are the ones who may have tetany. While the hypophosphatemic one, they will not have hypotonia. They are less prone to develop tetany.
एक मिनट टी-शर्ट वरती पण
हाँ, पहले चलता फिरता घूमता और भागता लिखता था। अभी जैसे 4 साल का था ना, नॉर्मली था, हो गया उसका, तो धीरे 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 करके उसका बैठना उठना बहुत कम हो गया। ऐसी anthropometry, weight is 14.4, which is less than -3 standard deviation. Height is 95 centimeter, which is less than -3 standard deviation. BMI is 15.96, which lies between 0 to +1 standard deviation. Upper segment to lower segment ratio is 1.1. Impression for anthropometry is stunted and underweight. On head-to-toe examination, there is no palarectrous clubbing cyanosis. Frontal bossing is present. Dental caries is present. On the chest, there is bleeding at the costochondral junction, which is present. On the extremities, there is double malleoli present, wrist winding present, and bowing of legs is present. Those are the pictures I took. On systematic examination per abdo, not significant, no organomegaly, soft non-tender. On CNS examination, tone was also normal. Power was more than 3/5. Reflexes are 2 plus. On respiratory, air entry, palatal equal. And on CVS examination, S1, S2 heard no murmur. 6-year, 3-month-old boy, fourth by birth order, born of non-consanguineous marriage, brought by mother with complaints of deformity of legs since 1.5 years of age, increased urinary frequency since 4 months, with complaint of not gaining adequate height and weight, normal by birth, immunized till date, developmentally isolated gross motor delay present, anthropometrically underweight and stunted with signs of rickets, is most probably a case of rickets. So this the investigations we had, like I have traced all the investigations from the start. So this was November 22 and July 23. Then some, yes. So in November 22, when the child sought medical. So in November, when the X-ray was done, we can see that there's spraying. There's also some spraying present. And this is July 23. This is September 23, when the hands X-ray were done for the first time. Here also we can see that there is spraying and spraying in the wrist. And these are the recent ones done in May and June.
When you read the chest X-ray, there is A, B, C, D, E, F, G, H. A for airway, B for bones, C for cardiac shadow, D for diaphragm, E for exposure, G for gastric bubble, H for hilum. Look at all that. Bones are also important, and many times thalassemia, rickets, X-ray chest is put up for your interpretation. And our idea, of course, in a good chest X-ray, here, for example, you can see all epiphyseal enlargements or cupping, praying, etc. at all levels. Okay. Sometimes the costochondral junction beading looks like almost some tumors in the lungs and things like that. So take a note of all that. Okay. Uh,
The white line will come only after the treatment has started. Now, if this is the white line will come here, the white line will come here. That means there will be a gap seen between the cupping and the white line. And later on, the white line will progress in this direction. Yeah. So yeah, there will be white line here and then the white line will start here coming down. So there will be, when white line appears, there will be some interval where there is a radiolucent area, which is the lower end of the bone, and because where the light line appears, that is exactly the anatomical site of bone. The radiological length of the bone is less than the anatomical length of the bone. Only what is calcified is seen. So white line will come here, it will be looking little white, and then it will come gradually. To explain cupping fraying, this is cupping. Why does cupping occur? Number one, you know that there is the rickets, the disease of growing bones, and here what happens is there is not only calcium deposition at the epiphysis, but there is some calcium deposition occurring at periosteal region also. So here the periosteal region, the deposition of calcium is relatively better. So up to here, the deposition is better at the deposition, and therefore you get cupping plus the effect of the weight that is there. Fraying is because you know that from this side the blood vessels are there, from this side the calcium is there, and there is a calcium which is deposited at a line. This particular invasion of the blood vessels is erratic, irregular, not in a straight line. So you get fraying because of that. So cupping, fraying, and of course the deformity. When you start treating, you'll see the white line here, and then the white line will go up.
So these are the investigations that were done. What I want to show is that the calcium was within the normal range. The phosphorus was low on the lower side. ALP was raised, and the renal function tests were within normal limits. Yeah, parathyroid, but it hasn't been done. We have done it now. Now the child is admitted. We have done PTH levels. The report is awaited. And currently the vitamin D we have done is 13.7. This is the first documented we have. And like whole exome sequencing was also done for this child recently only. And it was normal, no significant variant related. Earlier he was given cholecalciferol sachets, calcium supplements. Everything was going on till now. Like since last 1 month, mother was taking supplements regularly only.
So then why didn't he respond?
So like we are thinking of vitamin D resistant rickets only.
So then you've not picked up any genetic defect.
No. We have not yet reached the diagnosis. We are waiting for PTH levels. We also sent 24 urinary calcium, phosphorus, everything.
And this is your 25 hydroxy, no?
Yeah, 25.
So you've done 125 levels.
No, we have not done that. That is very costly.
You need to do that 25 hydroxy, 125 hydroxy, and also the PTH, because sometimes the the vitamin D maybe because the 125 deficiency is there, then the further conversion is not. So you have to see not only vitamin D and further metabolites of vitamin D, and that gives you the diagnosis where the defect lies. So you need to do all that.
Yes, sir.
Normally you do 25 OH only. Rarely you do 125. The reason is the serum levels of 125 are very transient. But when there is a problem, really, yes, you will have to do 125 as well. Vitamin D dependent rickets, for example. So this is 25 OH is fine. In fact, the only reason to do 25 OH is a vitamin D deficiency. Everywhere else, that is bound to be normal, right? But good. I think we must congratulate her for getting the whole picture of the child, multiple deformities, multiple x-rays, and I think she has taken an extra effort to do that. So that's quite worth it. Yeah.
And sir, she's the first poster.
Yeah. That's why she's so she's looking at me and said, at one time you were also like this. Yeah.
Very good. So Dr. Kore is asking, is this vitamin D resistant rickets?
And sir, she's the
So
first post.
clinically, I think we would think that, because if he has got so much of vitamin D and still not responded, then it has to be resistant. So we need to work out on that. So you know that there are two types of resistant rickets. One is where you're not getting 125. So there you will find levels of 125 low. And the second is you are converting it to 125, but it is not, the receptors are not there. So you'll get very high levels of 125 and still he is still suffering from rickets because it's not acting, right? So that we need to try and find out.
And in the management, to prove that it is refractory, right? I mean, refractory, first you give a big dose of 6 lakhs unit, preferably intramuscularly, so you have ruled out the malabsorption. And you repeat the same thing again after 2 weeks. And if you don't get any response in the form of healing, then you may call it as refractory to vitamin D. And as you rightly said, then you have to have 25 hydroxy and 125 hydroxy to find out where is the defect and then the further manage.
Okay, we'll stop here. Any questions, any comments from Archana ma'am or anybody else online? Okay, thank you. Thank you, and we see you next Thursday. Okay, thank you.
Deformity will take a long time to
Anybody
go.
else
And
on-
No,
these
sir,
deformities
everything
will
was well
require
audible and
surgical
we could
correction.
hear everything loud and clear.